surgical emergency.
Extending from the cecum into the right iliac fossa, the healthy appendix rests as a simple, blind-ended pouch. This surgically removed specimen reveals the toll of pathology. The tissue is engorged and necrotic. The cause rests below, a hard Faecolith that lodged in the entryway. This clinical sequence defines acute appendicitis as a mechanical, closed-loop obstruction crisis. The specific nature of the blockage is dictated by the patient's age and environment. In pediatric and young adult populations, the blockage is typically an immune-mediated event. Lymphoid follicles embedded within the appendiceal wall swell in response to infection. This hyperplasia pinches the narrow lumen completely shut. Older adult populations are more likely to present with a physical obstruction caused by a Faecolith. These calcified masses are linked to Western dietary habits. High fat and low fiber intake predispose the bowel to constipation and the formation of these obstructive stones. Anatomical variations, such as a long retrocecal appendix, naturally receive less blood flow to the distal tip, making the organ highly susceptible to ischemia once blocked. Age and dietary factors create the vulnerable environment. The resulting mechanical blockage serves as the physical trigger for the disease. The pathophysiology begins inside the lumen at the point of obstruction. As a Faecolith lodges in the neck of the appendix, the distal mucosa continues to secrete mucus into the now closed loop. Because the organ has a fixed, non-expandable volume, this continuous secretion causes the intraluminal pressure to begin steadily climbing. This rising pressure drives the entire disease process, effectively turning the appendix into a pressure cooker. The organ's own trapped secretions generate the escalating internal pressure that initiates localized tissue destruction. These top nodes of the clinical flowchart show the first point of failure. Rising pressure compresses the low-pressure venous and lymphatic drainage networks within the appendiceal wall. This fluid entrapment leads to rapid edema and swelling of the organ tissue. The secondary failure occurs when wall pressure exceeds capillary perfusion pressure, which chokes off the arterial blood supply entirely. Following the flowchart to this lower section, the loss of blood flow leads directly to ischemia, infarction, and gangrene. Pathological observation shows a predictable color shift. The tissue moves from healthy pink to red congestion, green gangrene, and finally blackened necrosis. Due to vascular geometry, the distal tip of the appendix suffers from this necrosis first and most severely. The appendix strangles itself from the inside out, creating a necrotic zone vulnerable to bacterial invasion. This chart tracks the progression to the bacterial stage, highlighting the step where luminal bacteria leak directly through the dying ischemic walls. Specific microbes, such as Bacteroides fragilis and E. coli, thrive in the stagnant loop, leading to suppuration and the formation of pus. Chemical mediators released from the dying tissue trigger systemic alarms, resulting in fever, tachycardia, and an elevated white blood cell count. Initially, the stretching of the organ causes a vague, visceral pain centered around the umbilicus. This diagram shows the anatomical trigger for localized pain. The inflamed outer serosa of the appendix makes physical contact with the parietal peritoneum of the abdominal wall. This contact stimulates somatic pain fibers, causing the pain to migrate and intensify over the exact site of the appendix in the right iliac fossa. The arrival of sharp, localized pain indicates that the inflammatory process has reached the outer wall, signaling an active breach of the organ's barrier. Once the wall fails, patients face two outcomes: structural containment or perforation. Pediatric and elderly patients often follow the left path toward rupture, as their anatomy prevents localizing the infection. In healthy adults, the greater omentum wraps the appendix, forming a localized phlegmon. While most cases stem from physical blocks, an alternate non-obstructive pathway exists where infection begins via haematogenous spread. In these cases, blood-borne pathogens cross from internal capillaries to directly invade the mucosal tissue, bypassing the luminal dilation seen in obstructive cases. Whether initiated by a physical stone or a blood-borne pathogen, the endpoint is identical: a compromised barrier and a bacterial siege. We must view the entire right iliac fossa macroregion to understand the diagnostic challenge. Localized somatic pain indicates peritoneal inflammation, meaning other regional abdominal crises can perfectly mimic appendicitis symptoms. Ileum inflammation from Crohn's or Yersinia generates a matching pain signal. Colon issues like volvulus or carcinoma create identical obstructions. Distant failures like ureteric colic, perforated ulcers, or pancreatitis refer pain into this exact zone. Physicians even encounter stump appendicitis, a recurrence of inflammation in the residual tissue of a patient who has already undergone an appendicectomy. Acute appendicitis is a biomechanical race against internal pressure. Identifying this sequence of obstruction, ischemia, and necrosis differentiates the true crisis before a rupture occurs.